Now, since you can see the atrial activation designated by the P waves, you can try to diagnose structural abnormalities in the heart based on the morphology of the P waves. So if you see that the P wave is very tall, especially in lead 2, then you think of right atrial abnormality, because right atrial abnormality will cause increase in the height of the P wave. If you see the P wave is very wide in lead 2, then you think of left atrial abnormality. And again, in V1, the initial part of the P wave is the right atrial, the latter part is the left atrial. So if you have a left atrial enlargement, you will see a significant second component, which is big in V1. And in lead 2, you will see a wide, broad duration of the P wave, which is called P mitral, because it's one of the reasons you see left atrial abnormality is in patients who have mitral stenosis. P pulmonale would be seen in patients who have pulmonary hypertension and have right atrial enlargement, or patients who have COPD, they can have that. Now, the electrical activation of the heart, as you can see in the cartoon over here, it starts from a structure called the sinus node, which is where all electricity from the heart starts. And then that spreads to activate both the upper chambers of the heart, which is the right atrium and the left atrium. Then the conduction goes from interatrial through to the AV node. There are different inputs to the AV node from the atrium. And the AV node acts like a filter, and then it conducts through the AV node, through the bundle of His, to the left bundle and the right bundle to activate the left and right ventricles. So this is a pattern of normal conduction that you notice that is present in everybody. You can have problems of the sinus node. So the sinus node can, if it is normal, we call it normal sinus rhythm. If there is variation in the P to P interval, we call it sinus arrhythmia. If the sinus load is beating too slow, so the normal sinus rate is generally thought to be between 60 to 100 beats a minute. So if it is less than 60 beats a minute, it's referred to as sinus bradycardia. If it is faster than 100 beats a minute, we call it sinus tachycardia. If there is no sinus activity, we call it sinus pause or arrest. And there are different versions of this. They are classified as sino-atrial exit blocks, which I'll show you how to diagnose. So the normal rate of the P waves is 60 to 100 beats a minute. And you can calculate that on a regular 12-lead ECG based on the duration. As I told you, if it's in a 25 millimeter speed, this one small box is 40 milliseconds. So 40, 80, 120, 160, 2. So you know that that is 2 milliseconds. So you can go from here to here and calculate this, and you can come up with the heart rate. If it is between 60 and 100, it's a normal heart rate, what we call sinus rhythm, normal sinus rhythm. Then the other thing we look at is the P to P interval. Is it pretty constant, or there is significant variation? Now, there might be some little bit of variation when you record the heart rate, because it's not always the same. We have different inputs going to the heart from the sympathetic system, from the parasympathetic system. But if you notice that there is significant variation in the P to P time, then we usually refer to it as sinus arrhythmia. If the sinus rate is beating too fast, more than 100 beats a minute, call it sinus tachycardia. If you were to start exercising, or you were suddenly excited, or you were afraid or something, then anything that causes increase in sympathetic tone to the heart will increase the heart rate, and you will have sinus tachycardia. If the sinus rate is very slow, then you call it less than 60 beats a minute, is sinus bradycardia. Sinus pause or arrest means that you have normal sinus rhythm going on, and then suddenly you have no sinus activity. which means you don't see P waves. And so if you see pause where you don't see P waves, then we refer to as sinus pause or sinus arrest. If the P to P interval, if this pause is some multiple of the previous P to P interval, then we refer to it as sinus exit block, type 2. If it is not a multiple of that, then it's called sinus exit block, type 1. If you don't remember exit blocks, you can just think of it easily as a sinus pause, and different variations depend on what the interval is as compared to the P to P interval that started it. So this is showing you an example of second degree type 2 or type 2 sinus exit block. So basically, as I told you earlier, here the P to P interval was 1080 milliseconds and the pause was twice 1080 milliseconds. So you know that this is type 2 exit block. And the pause is not a multiple of that interval, then it's a type 1. Type 1 means there is slowing of conduction. So you see sinus conduction is slowing, and then it blocks. Whereas over here, it's the same, and then suddenly there is a block. And this pattern that is called type 2 exit block. This is called type 1 exit block. And we'll see the same kind of blocks when we look at conduction in the AV node. AV node conduction is a little bit easier to understand as opposed to the sinus pauses. So what are the different abnormal rhythms you can get with atrium? So this is in terms of faster rhythms. So you can get extra beats coming from other parts of the atrium. So not necessarily the sinus node, but other parts of the atrium can also beat. So when you get that, we call it APC or PAC, which is premature atrial contraction. Okay. It can come from the right atrium, it can come from the left atrium. You can look at the morphology of the P wave and you can pretty much predict where it's coming from. So one simple rule for us when we see an extra beat or premature atrial contraction is we look at V1. In V1, I told you the first part of V1 is because of activation of the right atrium, and the second part is activation of the left atrium. Left atrium is very posterior, right atrium is very anterior. So V1 is lying here. If you have extra beats coming from the posterior, the back of the heart, V1 is very anterior. So they will be going towards V1. So if you look at those extra beats, V1 will be positive, or terminally it will always be positive. So if you see a very positive extra beat with a positive component in V1, you should think of it as coming from the left atrium. Whereas right atrium is an anterior structure and V1 is an anterior lead. So if it comes from the right atrium, it will be going away from V1. So here, if you look at V1, it will be a negative P wave in V1. So that's the simple rule of differentiating right atrial extra beat from left atrial extra beat. And again, we will use the same rule when we look at right and left bundle branch block. So you can have these extra beats coming from the atrium, which are called PACs or APCs. You can have sustained fast rhythm from here, which is called atrial tachycardia, which can be coming from one place or different places. So that is called multifocal versus simple atrial tachycardia. Or you can have other fast rhythms which are labeled atrial flutter, atrial fibrillation. And I'll show you more examples of that with cartoons so you can understand them very well. So this is a classification of fast rhythms coming from the upper chamber of the heart. So it is referred to as supraventricular tachycardia. So all of the fast rhythms coming from the upper part will be classified under this. So if you look at the broad classification, the one diagnosis that is predominant would be atrial fibrillation. And there is a category called paroxysmal supraventricular tachycardia. Now this is more than anything else, but this is not one tachycardia. This is a combination of different tachycardias. So if somebody tells you what is the number one cause of fast rate coming from the upper chamber of the heart, then you're going to say it is atrial fibrillation. Then the number 2 would be atrial flutter. Then the other would be multifocal atrial tachycardia. PSVT is a rhythm disorder which is characterized by paroxysms of very fast regular tachycardia, and they include AV node reentry tachycardia, AV reentry tachycardia, and atrial tachycardia. Again, we'll go to the next slide and see what they mean. Okay, so this is 12 lead ECG in a patient, and you have all the 12 leads: lead 1, lead 2, lead 3, the augmented limb leads, and the precordial leads. You can see that the heart rate is fast. So it's close to about 150 beats a minute, because one big box is about 300, two would be 150. So it's between 150 and 200. So that's the fast rate. And you can see that the QRS complex is narrow, so which means it's going through the conduction system. So this would be referred to as supraventricular tachycardia. This is an example of what we call AV node reentry tachycardia in supraventricular tachycardia. And let me show you what that means. So the AV node was a conducting tissue between the atrium and the ventricle. Some patients have two ways to go down the AV node. One is called the slow pathway, one is called the fast pathway. In these patients, they suddenly go down the slow pathway and they come back up the fast pathway. So normal conduction is going through fast pathways. They get an extra beat that blocks in the fast pathway, goes down the slow pathway, and now the fast pathway is ready to conduct back, and they can come back up the fast pathway, and then that is the kind of tachycardia they go in. When this happens, we refer to it as AV node reentry tachycardia. And there is a particular way of picking this up, and that is by looking at the ECG. If you compare this to the old ECG, you get a pattern in AV1 where you see a pseudo R prime pattern. But towards the end of the QRS complex, you see a small R wave, which is called pseudo R in V1. And in the inferior leads, you see that correlates with what we call S wave. So we call it a pseudo S wave. If you compare in sinus rhythm, this patient will not have that in sinus rhythm. If you see this pattern, pseudo R or pseudo S wave in tachycardia, which you don't see in sinus rhythm, you should think of AV node reentry tachycardia. This is the second most common cause of PSVT, which you are seeing in this slide. Here you see P wave followed by a short PR interval. So see P wave and a QRS complex. So this is less than 120 milliseconds. So that, and you see sort of a P wave, you see what we call a delta wave, and then you see a wider QRS. When you see these three things, short PR, delta wave, wide QRS, we call it WPW syndrome or Wolff-Parkinson-White syndrome. If you see that, then you should suspect that most of the fast rhythms in these patients are coming from this disease called Wolff-Parkinson-White syndrome. But you have to suspect it and pick it up on an ECG. And the way to do that is to look for a short PR interval, a delta wave, and then a wide QRS. And so these patients can also go into a fast rhythm, which has a narrow complex, supraventricular tachycardia, and it's regular. However, in these patients, instead of having a pseudo S wave or a pseudo R wave, they have more of what we call short RP tachycardia, or the P waves are a little bit away from the QRS complex. And it usually manifests as if they are having ST depression during tachycardia. You can see that this is the baseline, so the ST segment has gone down, And whenever you see that, you should think of a tachycardia involving a WPW pathway. The other way they can go into tachycardia is they can go into wide complex tachycardia, which is then referred to as pre-excited tachycardia. And which means that now they are going down the accessory pathway to activate the ventricle totally through the accessory pathway. So they are very wide. Again, I'll show you a cartoon. And one of the problems is if you don't pick this up right or treat it the wrong way, they can go from this to very fast ventricular tachycardia, and then they can die from that. So you really have to be very careful in these patients. This is a young kid, 16-year-old kid, who presented with atrial fibrillation, and he was going down conducting very fast through this WPW accessory pathway. So this is what happens in these patients. This is a cartoon to show you one location of a WPW. So as I said, in normal sinus rhythm, you have conduction starting from the sinus node, which then spreads through the atrium, through the AV node, down to the ventricles, through the right bundle and the left bundle. In patients with WPW, they are born with an extra muscle connection between the atrium and the ventricle. Now, in this would also be on the left side of the heart. Another way of going down to the ventricle, so that muscle conducts very fast. It does not have the decremental properties of the AV node. So the AV node allows conduction at 120 to 200 milliseconds from here to here. This does not have any such requirement. So this can conduct very fast. So that is why they have a shorter PR interval. They have a delta wave, which is a fusion of conduction from here and the AV node. And then because it goes from here, it can activate the ventricle with a wide complex. So that is why you have the third feature, which is a wide QRS complex. So they can go into tachycardia by going down the conduction system, coming back up the accessory pathway, so which is called orthodromic tachycardia. This would be a narrow complex tachycardia because it's using the conduction system. If they go the other way, which is antidromic tachycardia, which means they go down the accessory pathway and up the AV node, then it becomes wide complex tachycardia. The most common scenario they get is they get atrial fibrillation in the upper part. The upper chamber is beating fast and irregular, and that makes the lower chamber beat fast and irregular through the accessory pathway. The third kind of supraventricular tachycardia, or paroxysmal supraventricular tachycardia, which is regular, is what we call focal atrial tachycardia, which means there is just a focus in right or left atrium, which is beating very fast and just firing by itself. So when you look at PSVT, if you see the P wave right towards the end of the QRS complex, which is the pseudo R wave or the pseudo S wave, you think of AV node reentry. If you see the P wave a little bit after the QRS complex, wherein you see ST depression, you think of WPW with AV reentry tachycardia. If you see a long RP tachycardia, which means the distance between the P wave and the R wave and the next P wave is long, is beyond the T wave, then you think of focal atrial tachycardia as the mechanism. Now, the other causes of supraventricular tachycardia, which are not necessarily regular, are atrial flutter and atrial fibrillation. Atrial flutter, everybody should be able to pick up on the ECG, and this is a classic 12-lead ECG of atrial flutter. And this is what you see is you see these P waves, which have a sawtooth pattern. And you will see a lot more P waves much faster and more. So P waves are going at 300 beats a minute. And usually if these patients are not on any medications, the QRS goes at half the interval of the P wave. This patient is not doing that because he's probably on medications. So if you see somebody going at 150 beats a minute all the time, and you see some kind of a pattern like this in between the QRS complexes, you should give them adenosine or some drug to block the AV node, and then you will be able to see the sawtooth pattern of the P waves. So if you see sawtooth pattern, very fast P waves going like this in the inferior leads, this is an example of classic typical right atrial flutter. Okay, That you guys should be able to diagnose. And when you see this, you would need to call your cardiologist because the treatment involves a few different things. But this is an arrhythmia that is curable by catheter ablation uh, if you get the right people involved. And this is the circuit of atrial flutter. In atrial flutter, it's a what we call macro reentrant tachycardia. So it's a very big tachycardia. And here, what happens is the circuit is very big. So this is a circuit that goes in the right atrium. It goes around like this in a big loop like this. And so in these patients, you see a sawtooth pattern because this rhythm is going away from the inferior leads. So in 2, 3, and AVF, you see negative P waves, which are going away from 2, 3, and AVF. And they're going towards V1. V1 is right here. So in V1, you will always see positive. If you see very fast P waves, which are negative in the inferior leads, looking like a sawtooth pattern, positive in V1, you should think of it as typical right atrial flutter. And as I told you, the second clue is if the patient is not on drugs, the ventricular rate will be half of the atrial rate, which would be 150 beats a minute. So in patients who have irregular wide complex, narrow complex tachycardia, which means it's a narrow complex, but it's irregularly regular, then you think of atrial fibrillation, atrial flutter, and multifocal atrial tachycardia. When it is regular, I told you the three differentials, which was AV node reentry tachycardia, AV reentry, and atrial tachycardia.